afternoon, everyone, and thank you for joining us today. My name is Gabriela Passat, and I am the Vaccines for Adults VFA Program Coordinator with the Immunization Branch at the California Department of Public Health. And on behalf of our team, I would like to welcome you to our VFA Webinar 2018 Adult Immunization Schedule Update. Before I get started and turn things over to our presenters today, I would like to go over some logistics for the webinar. There are two ways you can ask questions. One is through the chat box. Please feel free to type in your questions at any time during the webinar. The second option is to ask questions via the phone at the end, and you've already heard the instructions for that. We will be addressing all the questions at the end of the presentations today. Also, we will be posting a copy of the slides and a recording of the webinar on the VFA webpage, and we will send you an email to let you know when these are going to become available. I do have another reminder regarding the next order period. So the next order period for VFA is going to be April 2nd through the 16th. Please start planning right now for your next orders and make sure you place your orders on time. And again, thank you for attending today's webinar. At this time, I would like to introduce the speakers today. Joining us, we have Dr. Robert Schechter. He's the Chief of the Clinical and Policy Section here at the Immunizations Branch. Dr. Schechter will be reviewing the 2018 Recommended Adult Immunization Schedule update. And then my colleague Nisha Gandhi, the Adult Immunization Program Coordinator, will go over some information we have for you regarding the zoster vaccine. With that, Dr. Schechter, I will turn over to you.
Thank you very much, and good afternoon, everybody. I'm glad to have the chance to talk to you over the next few minutes. Each fall, the Federal Advisory Committee on Immunization Practices votes on the schedule for the next calendar year, and that usually gets published sometime in February. And so we've just had the release of the 2018 immunization schedule, and I'm going to go over in the next few minutes some of the major changes in the adult schedule. Slides that I'm using today, some of them around shingles are from a CDC colleague, Dr. Kathleen Doolin, and some of the hepatitis B slides I'm going to show were kindly shared by Dr. David Kim, CDC. I don't have any financial interest in the immunizations discussed here, and I may or may not talk about off-label use of some of these vaccines. So the major changes to the schedule are around the introduction of a second shingles vaccine. And in that light, here's a little bit of background about zoster and post-herpetic neuralgia epidemiology in the United States. Over 1 million cases of shingles each year. As the immune system ages and the dormant varicella zoster virus reactivates with age, the incidence of shingles and its complications increase with age, so that the incidence for shingles in children is quite low, fewer than 1 in 1,000 cases population, whereas for the oldest amongst us, 80 years or older, the incidence can be well over 15 cases per 1,000. Similarly, the complications such as post-herpetic neuralgia become more common. They're primarily in those 50 years and older, with up to 1 in 5 shingles cases leading to severe pain, post-herpetic neuralgia. The first shingles vaccine has been around for over a decade now. That's the live vaccine, basically a very large dose of the same viruses in the chickenpox vaccine. And over the last decades, about 1/3 of individuals 60 years and older have gotten a dose of this vaccine, as indicated in the next slide, which shows the estimated coverage rates over the last decade, still quite low, but up to about 1/3 having gotten the first available vaccine. Next slide. So in October, the Food and Drug Administration licensed an additional vaccine, technically recombinant zoster vaccine, trade name Shingrix, which consists of an outer protein of the varicella zoster virus, a glycoprotein that's stuck into the lipid envelope of the virus. This glycoprotein is made recombinantly. And then along with this recombinant protein is a lipid-based adjuvant or substance to promote stronger immune response. The licensure came after large randomized clinical trials to evaluate efficacy and safety in persons 50 years and older. Next slide. So some key differences between the two vaccines. We already have heard here at the health department of practice where they got their first dose of the recombinant vaccine, were eager to use it and promptly put it in the freezer because that's how they were used to treating their live vaccine. And unfortunately, freezing quickly destroys the recombinant vaccine, and so renders the vaccine useless. And so key difference is the new vaccine gets stored in the refrigerator in contrast to the long-standing vaccine, which gets stored in the freezer. The recombinant vaccine is also given in a 2-dose series rather than a single dose, and is given intramuscular. Next slide, please. So last fall, the Advisory Committee on Immunization Practices made recommendations, which have been recently published, about the use of the shingles vaccines, that there's a preferential recommendation for use of the recombinant vaccine in persons 50 years and older, whether or not they've had chickenpox vaccine before, or whether or not they've had a dose of the live shingles vaccine. You do not need to screen patients for a history of chickenpox prior to administering shingles vaccines. And that the committee also recommended that while the live vaccine continues to be recommended for 60 years and older, the recombinant vaccine is recommended preferentially for this older age group. Next slide, please. So these are some of the results that led to those recommendations. The recombinant vaccine shown to have very high efficacy against herpes zoster, both in persons 50 to 70 years old, 97%, and still over 90% in persons 70 years and older. Also, high efficacy against neuralgia, over 90% in persons 50 years and older. And that seeing how the vaccine performs after years after immunization, how long does the protection last? There's data now 4 years out from administration, which shows high levels of protection continuing in persons 70 years and older. In contrast, the vaccine was shown to be safe in clinical trials with no differences in serious adverse events between vaccinated and control populations. When they're doing these trials, they assign grades to reactions such as injection site redness and pain and muscle aches or fever. And I think grade 3 reactions are typically those which limit activity for a short period after immunization, and grade 3 reactions were more commonly reported in those who received the recombinant vaccine, about 1 in 6 persons who had received it compared to those who had received a placebo control. Next slide, please. The rationale for preferring use of the recombinant vaccine over the live vaccine is not based on a direct head-to-head trial. There hasn't been a trial yet of comparing the two directly, but when you compare the two individually and see the efficacy rates from those separate trials, those are the comparison rates from 60 to 69 years, 97% compared to 64% for the live vaccine. In those 70 to 79 years and 80 years or older, it still have a efficacy about 91%, though it drops off with age to 41% of the 41% efficacy for live vaccine in those 70 to 79, and less than 20% in those 80 years and older. When they model how many more cases are likely to be prevented by use of the recombinant vaccine, big disease burden from use of the recombinant vaccine. Both vaccines are safe. The rate of local reactions is higher with the recombinant vaccine than the live vaccine. and overall modeling showing that greater benefits from use of the recombinant, the newer recombinant vaccine. Next slide, please. So this graphically shows some of the comparison, the results in terms of efficacy against occurrence of shingles, of outbreaks of shingles in patients. The yellow bars show the results for the new recombinant vaccine. The various shades of blue show different trials for the live vaccine, and the three different sets of bars are three different age groups: 50 to 59, 60 to 69, 70 plus years, and in each of the age groups showing again high levels of efficacy with the new recombinant vaccine and lower levels and quicker decrease or lower effectiveness with older ages, especially for the live vaccine. Here the outcome is post-herpetic neuralgia and similar results, although the live vaccine does prevent 60 to 70% of cases of post-herpetic neuralgia in those 70 years or older. The rates are even higher for the new recombinant vaccine. This is going 4 years out after vaccination. Next slide, please. These are trend curves for effectiveness years after immunization. So 1 to 11 years out for immunization. There's data now for the live vaccine, which has been around that long, and there's data now out to 4 years for the persons who've gotten the recombinant vaccine in trials. And you can see the red trend line, both a higher level of protection and in terms of the subtraction between what the effectiveness was at year 1 and year 4, a smaller drop for the recombinant vaccine compared to the live vaccine, which is in the blue trend line below. This just reiterates that if you've had a dose of the live vaccine before, you're recommended to get the recombinant vaccine, and that's probably that 1/3 coverage rate is probably about 20 million adults of the older age groups. And in a small study, giving the recombinant vaccine 5 years after a dose of the live vaccine did not affect either how well the recombinant vaccine worked or the rate of adverse events after immunization. Giving the recombinant vaccine after the zoster vaccine is still cost-effective, comparable to other adult vaccines, and most cost-effective at the older age groups, which continue to have that much higher gap in effectiveness between the two vaccines. Next slide, please. So, again, the new recombinant vaccine is on a 2-dose schedule, and dose 2 is recommended to be given 2 to 6 months after dose 1. If inadvertently dose 2 is given 4 weeks or sooner after dose 1, the recommendation is to repeat the second dose. If someone has had shingles before or a dose of the live vaccine, they're recommended to still get 2 doses of the new recombinant vaccine. How soon should someone get their dose of recombinant vaccine if they've gotten a dose of zoster vaccine in the past? There's no hard data on this, but based on expert opinion, a 2-month or more interval is recommended between that dose of the Zostavax and getting a first dose of the new recombinant zoster vaccine. Next slide, please. And again, while persons with a history of shingles in the past are recommended to get shingles vaccine, if someone is actively in the middle of their eruption of shingles, wait until the episode is over before immunizing them. The shingles vaccines are recommended for persons with chronic renal failure, diabetes, rheumatoid arthritis, chronic pulmonary disease, and there's great hope that the recombinant vaccine would be helpful for those with immunocompromising conditions, but additional data is being awaited before the advisory committee makes recommendations. So no recommendations yet, and it can be used, but that would be off-label use, and formal recommendations will be following at this time. So to recap the recommendations, for your patients 50 years and older, 2 doses of recombinant zoster vaccine 2 to 6 months apart, whether or not they've had shingles in the past, and whether or not they've received the live zoster vaccine before. If they have received the live zoster vaccine, wait 2 months before starting the 2-dose series. For your patients 60 years and older, you may give either vaccine, but the recombinant vaccine is preferred based on the efficacy results. Next slide. Contraindication to use of the new vaccine would be history of a severe allergic reaction, such as anaphylaxis to the vaccine or any component of it. Precautions would be a current eruption of shingles. Again, wait unless there was some compelling urgent need to wait until the acute eruption has subsided. And for pregnant or lactating women to weigh the benefits versus the unknown information about the safety of the use of the vaccine in these populations. As mentioned before, minor local reactions and minor general reactions, such as fatigue, are higher in the recombinant vaccine than in the live vaccine. And so it's advised to counsel your patients about what they might expect in the days after immunization, where most patients will have pain at the injection site, and many will have aches and fatigue. That being said, persons who did react to the first dose, there was no correlation between reactions to the first dose and reactions to the second dose in the large clinical trials. And persons should be encouraged to get that second dose even if they had reactions to the first dose. There's limited data on administering the new vaccine with other vaccines. Did not appear to be any interference with either vaccine when it was given the same time as an activated influenza vaccine. And there are ongoing studies on its use with polysaccharide pneumococcal vaccine and with the Tdap booster. The recommendation is that it may be given with other vaccines at the same time. And just a reminder, the new vaccine, store it in the refrigerator. The older live vaccine stays in the freezer. New vaccine goes in the refrigerator. And if either of them is put in the other cooler, it will go bad, so don't do it. All right, shifting now from shingles to mumps, just briefly. As you may have seen in your community or in the press, there have been lots of cases of mumps in the last few years around the United States, over 5,000 cases reported in 2016 and 2017, mostly in young adults, many of whom are in college settings. There also was a very large outbreak in Arkansas, which began in a Pacific Islander community in the agricultural and chicken and poultry farms and poultry farming communities in Arkansas. These communities all have in common intensity of exposure in close contact settings, especially college campuses, but not necessarily limited to them. As a result, there is an additional recommendation based on use in the last decade. Next slide, please. For a recommendation would reflect it in the schedule that if for persons after their first birthday who have received either 0, 1, or 2 doses of mumps-containing vaccine and who are believed to be at increased risk during a mumps outbreak are recommended to get an additional dose of mumps-containing vaccine, which in the U.S. means getting another dose of MMR combination vaccine. Okay, I'm going to talk for the next minute or two about hepatitis, and mostly hepatitis B, a little about hepatitis A. Over the last year, there are additional, the ACIP has come out with our hepatitis B recommendations, which reiterate long-standing recommendations to vaccinate persons with chronic liver disease, including persons with hepatitis C infection, cirrhosis, alcoholic liver disease, fatty liver disease, autoimmune disease, or clinical hepatitis based on transaminase results. Next slide, please. Despite these long-standing recommendations, a paper that just came out in the last week or two based on national health interview surveys shows low immunization rates, whether it's adults with chronic liver disease or adults without chronic liver disease. No higher than 12% of persons having the full series of hepatitis A vaccines and fewer than 30% having the full series of hepatitis B vaccines. So lots of room for improvement in immunizing adults in general, and especially the higher risk ones with chronic liver disease. The importance of this was really emphasized last year, next slide please, by the hepatitis A outbreak in California, primarily in San Diego, also a large number of cases in Santa Cruz and Los Angeles. High rates of hospitalization, 40 to 70%, over 20 deaths, and the majority of those hospitalization and deaths were in adults with comorbidity, especially chronic liver disease, chronic hepatitis infection, lots of folks who were using illicit drugs, which is also a long-standing recommendation for immunization of hepatitis A and hepatitis B vaccine. So these were folks who were recommended to get vaccine, and many of them ended up in the hospital, and some died without hepatitis A vaccine. So there has been recently licensed in November another hepatitis B vaccine for adults. It is single antigen, it is not combination, and it is now joins 4 other inactivated hepatitis B vaccines in the United States. This vaccine is recombinant, as are some of the others. Unlike the others, it has a different adjuvant than the shingles vaccine, but again, another substance which helps stimulate the immune response, in this case, a nucleotide adjuvant. It is also given in 2 doses, but in contrast to most hepatitis B vaccines are given in a 3-dose series with 1 dose interval between the 2 doses. Next slide. And these are the top data shows immune response compared to one of the 3 or 4 dose series of one of the other licensed vaccines, showing high levels of immune response both in healthy individuals and especially in those with chronic illnesses such as diabetes and chronic renal disease. The safety profile very similar to licensed product, both in terms of mild or serious adverse events or other rare events occurring after immunization. Next slide, please. I'm shifting from hepatitis B now to a couple of odds and ends that came up last week at each year. February is one of the 3 annual meetings each year of the Federal Advisory Committee on Immunization Practices. One of the things they talked about last week was this new hepatitis B vaccine, and another outcome from the meeting was that they voted to bring back as a recommended option for the fall influenza season, the live attenuated influenza vaccine, the nasal spray or flu mist product. As you'll recall, a few seasons ago, this was taken off the schedule as an option for healthy persons 2 to 49 years of age based on weak performance of the H1N1 strain in the vaccine. Although It remained a licensed product in the United States. It was not recommended, although it was continued to be used in other countries over the last few seasons, in Canada and some European countries. So in the meantime, the manufacturers replaced its H1N1 strain to address what it feels to have been the limitation of the vaccine in the seasons before it was moved, and it has a lot of data which is shared at the meeting on the immune response of the revised formulation, and some laboratory testing which showed comparable performance to when the vaccine was effective in its the early years of its use. There is no effectiveness data yet directly for a reduction in H1N1 disease, because the last few seasons there's been very little H1N1 disease in North America or Europe where the vaccine has continued to be used. We may or may not see effectiveness data from those countries this season before the end of the season, but there isn't any data. There aren't any data yet. So this will be an option for adults and for children up to 49 years of age who are healthy for the fall. Last week, the World Health Organization made its annual recommendation for strains to be used in the influenza vaccine for the fall Northern Hemisphere immunization effort and disease season. For the 4 strains in quadrivalent vaccines, 2 are the same. The H1N1 strain are the same, and the B Yamagata lineage strain are the same, but 2 strains are changed for the Northern Hemisphere for next fall. One is the H3N2 strain, and one is the B Victoria strain, which is in both trivalent and quadrivalent vaccines. Typically, the Food and Drug Administration adopts these recommendations, but for the Federal Health and Human Services Department usually makes a similar recommendation, but they're meeting right now and will come out with their recommendations shortly. The last topic for the moment was also discussed last week at the ACIP meeting, and this was revising slightly what to do when someone has been exposed to hepatitis A virus. What do you offer them? And the change here is that hepatitis A vaccine is recommended to be offered to everyone 12 months and older, where before this there was an upper age limit around 40 years, or some places a little bit older than that, based on some data from previous years that hepatitis A vaccine was recommended for younger populations but not older. Now it's recommended for all populations who've been exposed. And for persons 40 years and older, you can also offer immune globulin depending on your risk assessment on basically how likely is an older patient to be immunocompetent versus an aging or weakened immune system, and other factors can be considered as well. Final component to this hepatitis A consideration is that in parallel to what's recommended for older infants, 6 to 12 months, who are traveling internationally, comparable to what's recommended for them for measles, which is to get an early dose and then continue on with a regular 2-dose series. There's now a similar recommendation for hepatitis A, that older infants who may be exposed to hepatitis A overseas can get an early dose to help protect them, but get the regular series when they come back or after their first birthday. So again, I want to thank Dr. Duling and Kim for sharing their slides on zoster and hepatitis, and I appreciate your attention, and any questions you may have, try to help you answer.
Thank you, Dr. Schechter. I think what we will do is we only have a couple of slides after this, so we'll talk about the Shingrix rollout materials, and then we'll open up for questions for any of us. But before we move into the next, we do have a poll question, and that's going to pop up soon on your screen, and it's just for us to get a sense of whether or not you're offering Shingrix already to your non-VFA eligible patients. We've received many questions about this vaccine, and we wanted to just check in with all of you and see whether or not you are offering it right now. Because I know it's been available for a couple of months now in private sector, so it's been out there. And we're just curious to see whether or not you've ordered any and if you're administering it already to patients. So the poll is now open, and I think it's ended, and I don't have the results. Cecilia, do you have? Oh, we do. Okay. So it looks like the majority of you are not offering it right now, but there are a few of you that are. So six clinics are offering it currently. So thank you for completing that quick survey or poll for us. And we'll just quickly move into the next update. And unfortunately, we don't have a lot to offer you right now. So as a reminder, the vaccine offered through the Vaccines for Adults program is federally funded. And in order for those doses to be available, the federal contracts have to be in place first. And we are waiting to hear when those contracts will be finalized and the doses will be available at McKesson for ordering. So we have heard that it'll either be the beginning of Q2, which is April, or Q3. And what we're hoping to do is once we get more information, we will try and either extend the ordering period if need be, depending on when the doses are actually available. So we are cognizant that many of you are interested in having this product, and we'll do what we can to adjust the ordering cycle that we have set up previous to Shingrix availability to allow ordering of this product. Again, it is a 2-dose series, and it's licensed down to 50 years of age, which things that you'll have to keep in mind. When you're placing your orders. So as many of you, you're all VFC providers, and you know that when a new vaccine rolls out, there's usually a letter that comes out that sort of describes some of the clinical aspects as well as the ACIP recommendations and then availability through the program. So our intent is to create a similar letter for VFA providers around the new vaccine, and that also will be timed with the availability of the doses. So it'll go out in the same manner that we've sent out other notices, so through our VFA listserv. And then I think something that has come up is whether or not what to do with patients who come in who are VFA eligible and you have Zostavax, whether or not you should continue to offer this product or wait for Shingrix. And because we don't have Shingrix to offer you, we think you should just continue to offer Zostavax, knowing that in 8 weeks or so they would be eligible for Shingrix. So we have no doses to give to you now, and so many of you did order small amounts of Zostavax in the last ordering period in January, and so continue to offer Zostavax until Shingrix is available. And then Dr. Schechter did a really nice job of sort of the description of the two products. But just a reminder again about the difference between Shingrix and Zostavax. Storage is a big, big deal with this vaccine. So again, the RZV vaccine is refrigerated while Zostavax is frozen. One is live and the other is a recombinant vaccine. Again, the route of administration is different. And again, Shingrix is a 2-dose series while Zostavax is a 1-dose. And again, the age difference as well for these vaccines. I think that is all I have right now. So why don't we go ahead and, operator, if you've got any questions, we'll go ahead and open up for questions.
Thank you. If you do have a question, please press star followed by the number 1 on your touch-tone phone. You'll be prompted to record your first and last name. Please check that your phone is unmuted before you record your name. If you then decide to withdraw your request, you can press star 2.
And while we're waiting for those questions going up, we did have something come in via WebEx, and whether or not the new vaccine will be covered by Medi-Cal. Our assumption is that it will be, but we have not seen any information yet. It usually takes a number of months for the insurers to come on board after an ACIP recommendation is made. And I believe the ACIP recommendation for this vaccine was only recently published. So it will take a number of months before Medi-Cal will, but I do believe Medi-Cal is retroactively covered. Right.
And I think we have heard that also the manufacturers are proactively working with Medi-Cal, and so the latest we have heard is that they are making great progress. Which, this process usually takes a long time, but I think he may be fully covered soon.
Same with Medicare as well. So we fully expect both to be covered by Medi-Cal and Medicare. Operator, do we have any questions?
We have none at this time.
So
again, you can press *1.
Okay, go ahead. One additional question that just came in, will the presentation be emailed to us to share with our providers?
We will post the presentation online, and this has been recorded, and so the audio file and the slides will be available on the VFA portion of the EVIZ page in the next few days. I'll check in again. Operator, do we have any questions?
We have none.
Okay, and nothing else has come in via WebEx. Looking around to see if there's any.
Well, you know where to find us. On the last slide, we have our email address, and I guess with this, I would like to thank our presenters again today, and also thank you for attending our webinar, and you will be hearing from us in the next couple of days. Thank you.
Thank you.
This does conclude today's conference. Thank you for your participation. All parties may disconnect at this time. Speakers, please stand by for your post-conference.